Hello, and welcome to another live broadcast with MedStar Health. My name is Amy Cameron, and today I'm joined by 5 specialists from MedStar Georgetown Cancer Institute, Dr. Dana Sloane, Dr. Priyanka Kanth, Dr. Reetu Mukherji, Dr. Brian Bello, and Dr. Luther Ampey discussing colorectal cancer. March is Colorectal Cancer Awareness Month, a month dedicated to increasing awareness about this prevalent disease. Colorectal cancer is impacting an increasing number of Americans with a projected 153,000 new diagnoses this year alone. What's concerning is that more individuals under the age of 50 are being diagnosed more than ever before. That's why it's important to understand the risk factors, including genetic predispositions, recognize symptoms, and explore diagnostic and treatment options for colorectal cancer. So stick around to learn more. Give us a like to let us know you're watching. And if you have any questions for our experts, leave them in the comments below. Before we get into our questions, let's learn more about our panel of experts. Dr. Dana Sloane is a gastroenterologist. Welcome.
Thank you.
Would you tell our viewers about yourself?
Of course. I'm a gastroenterologist here at MedStar Franklin Square Hospital. I serve as the site director here. I've been in practice for 19 years. I enjoy what I do, and I'm very passionate about colorectal cancer screening.
Great, thank you. Dr. Priyanka Kanth, gastroenterologist and cancer genetics specialist. Welcome.
Thank you. I am faculty here at MedStar Georgetown University Hospital in gastroenterology. I do run the GI cancer prevention program here, and my core interest is in GI genetics and colon cancer prevention.
Thank you. Dr. Reetu Mukherji, medical oncologist. Thanks for joining us.
Thank you. I'm happy to be here. I'm one of the gastrointestinal medical oncologists here at Georgetown University Hospital, and I'm very interested in clinical trials for our colorectal cancer and gastrointestinal cancer patients, as well as novel biomarkers, and I have a very strong research interest, and happy to be here today.
Thank you so much. Dr. Brian Bello, colorectal surgeon. Thank you.
Thanks for having me. I'm Brian Bello. I'm one of the colorectal surgeons, the regional chief of colorectal surgery in MedStar South. I'm mostly at Washington Hospital Center, but also spent time at MedStar Montgomery Medical Center. Happy to be here.
Thank you. And lastly, Dr. Luther Ampey, radiation oncologist. Thank you for joining us.
Good afternoon. I'm Luther Ampey. I'm the medical director of radiation oncology here at MedStar Montgomery Medical Center. I'm also the medical director of the service line here as well. I've been in practice for about 20 years, and I'm very happy to be here as well.
Thank you. Okay, so let's get into some questions. We're going to start with risk factors. What is colorectal cancer?
Colorectal cancer is really any tumor or cancer involving any portion of the colon or rectum being the bottommost portion of the colon.
Okay, and is there a difference between colon and rectal cancer?
You'll definitely hear later from some of my colleagues that treatment can be very much different between colon cancer and rectal cancer. But from a screening and from a diagnostic standpoint, from a patient perspective, they are essentially part of the same continuum. So all residing within the colon proper.
Okay, so focusing on colorectal cancer, what are the signs and symptoms?
I think it's important to understand that many patients with colorectal cancer will not have any symptoms. Some patients may experience signs such as abdominal pain, blood in the stool, bleeding from the rectum, a change in their bowel habit, meaning a change in the size of their stools or the nature of their stools. But many patients who we diagnose with colorectal cancer or advanced colorectal polyps won't in fact have any symptoms. And that's why we have to be so intentional about screening because many patients who are diagnosed never have any symptoms to begin with.
And can it be prevented?
Yes, there are definitely important steps that all of us can take, maintaining a healthy diet, maintaining a healthy weight, and getting good physical activity, not smoking or minimizing tobacco use, understanding our family history. So understanding about our mom, our dad, our siblings, our children, and really having those conversations about a person's medical history, our family's medical history. And of course, there is no prevention like being appropriately screened. And we'll talk some about that during our conversation today.
Great. You did mention a little bit about diet. How much does diet and exercise impact someone's risk?
Well, it's very well established that being physically active and consuming a diet that's higher in fiber and lower in fat can be protective against colorectal cancer. So it's not to say that, if you are physically active and you do have a healthy diet, you are not at risk. But those are factors within our control that we can certainly try to maintain to minimize or reduce our risk of colorectal cancer.
That makes sense. How is colorectal cancer diagnosed?
In general, through screening. Many patients will come to see any one of us with symptoms or with abnormal imaging, and so those patients are diagnosed through a different pathway. But screening is really critical. In 2018, the American Cancer Society lowered the recommended age for colorectal cancer screening from 50 to 45 for average risk individuals, for those who are considered to be at higher risk of colorectal cancer. So those who have a personal history of inflammatory bowel disease, for example, or those who have a family history of colorectal cancer or advanced polyps. That screening age will be younger, starting at age 40 or even earlier, depending upon one's family history. But in general, colon cancer is going to be detected through screening modalities.
You mentioned this a little bit, but how would somebody know when it was time to get screened, when they needed to be screened?
So in general, if you're 45 or over, you need to be screened. However, again, knowing your family history, understanding your family history and your own personal history, that's going to be a critical conversation to have with your primary care provider so that he or she can guide you as to when you should start being screened and what your best screening options are. But in general, if you are age 45 or over, you do need to be screened for colorectal cancer.
And is a colonoscopy the only way to be screened for colorectal cancer?
Definitely not. There are multiple options for colorectal cancer screening in the US. There are basically two main buckets of screening options. One are options that test the stool, and the other bucket are options where the colon is visualized in some way. So to break that down, options that include stool testing are FIT testing, where once a year, a patient will submit a stool sample that's analyzed for essentially microscopic blood in the stool. There's also an every 3-year option called Cologuard, which is DNA-based stool testing, a slightly larger stool sample that's meant to detect genetic changes, if you will, in the stool. These are both non-invasive options. They are options that we leveraged very heavily at the onset of the COVID pandemic when nobody was really doing colonoscopies, everything was shut down. And truthfully, for patients who can't get time off of work or who don't have transportation or who just don't want to have a colonoscopy, those are indeed acceptable and well-vetted, approved options for colorectal cancer screening. The other bucket, if you will, are screening options that involve directly visualizing the colon in some way. The main option there, of course, is colonoscopy, which we provide here every day here at MedStar Health. But there are other options, including virtual colonoscopy, which is a CAT scan of the colon lining. There are even capsule studies looking at the colon that are not really widely used, and other options that are probably further down the line. But that's the other main bucket of options for colon cancer screening.
Now, some of those options that you mentioned don't require someone to go under anesthesia, because I know that's a concern for some patients.
Correct.
Were those just the stool sample options?
So really the only test that's going to require any form of sedation is going to be colonoscopy. I think it's important to differentiate sedation and anesthesia because most patients who undergo colonoscopy do not need complete anesthesia. Rather, it's intravenous moderate sedation. So colonoscopy being only a 15 or 20-minute procedure, we don't require patients to undergo general anesthesia. The other options that I listed, even things like virtual colonoscopy or any of the stool-based testing options, of course, don't require sedation of any kind.
Great. Are there other diagnostic tools available, and are some of the screenings more effective than others?
So what we know is that, in comparative studies, for example, between FIT testing and Cologuard, for example, there's probably a higher degree of sensitivity for Cologuard-based testing. With either stool-based options, you do run into issues with false positives. In other words, if a patient comes in with a positive FIT test or a positive Cologuard, many of those patients do not, in fact, have colorectal cancer, so there are some issues there. In terms of colonoscopy, it is considered to be the gold standard for colorectal cancer screening because it's not only a screening modality, it's also a preventative modality in the sense that we are able to detect colon polyps, which we'll talk a little bit about later. In identifying and removing colon polyps, we can also decrease a person's future risk of developing colorectal cancer. So in that sense, colonoscopy has been kind of billed as the gold standard because it's not only diagnostic and screening, it's also preventative in a way.
That segues perfectly into my next question. What is a polyp?
I'm happy to take that. So polyp are these little, I explained to my patient, these are little bumps or growths in colon that has potential to turn into cancer. And not all polyps will turn into cancer. And that's the reason we do colonoscopy. We can see them, we can remove them. And then our pathologist colleague help us with pre-cancer and how do we follow these patients. So most of the polyps can be removed at the same time. I would say 90% of the polyps can be removed. Sometimes they're too large or complex polyp, and we may need help of our advanced endoscopists and sometimes our colorectal surgeons and colleagues to remove those large polyps may require even removing part of the colon. So, but in all practical purposes, most of the polyps can come at the same time because they're small and usually not complex.
Okay, great. Thank you. What part, we're switching gears a little bit to genetic risk factors. What part does genetics play in the risk of developing colorectal cancer?
Absolutely. So genetics is a small part, but a big part, I say that. Around 20 to 30% of all colon, I would say all GI cancer, we can potentially find a genetic alteration or genetic mutation. 70 to 80% still sporadic. The younger the patient is, the higher chances of finding a gene alteration that could explain cancer in that patient. So finding that 20 to 30% of cohort is highly important because, for example, I always give an example of a condition called Lynch syndrome, and I think we're going to talk about that maybe a little bit more in detail. The reason I bring that up is it's a very common hereditary cancer syndrome. And it increases your risk of colon cancer from average risk of 5% to up to 50 to 60%. And the major difference is we start everyone's to start screening at age 45 if they're not high risk from family history. But if they have a gene mutation like Lynch, we start screening at age 20, age 25, age 30. And that's a very big difference. So knowing that piece is very important, that you could be carrying a gene mutation and knowing your family history. And that's why having an understanding like who could be carrying, and there are ways to find those. It's not perfect, but knowing the genetic risk really changes when you start screening because colon cancer is preventable. We can remove polyps, we can potentially prevent most of colon cancer.
Wow. Does MedStar Health offer genetic counseling?
Absolutely. So that's the first place. If you feel, and I think we're going to talk about that, if you think you could be high risk based on family history or you know someone carrying a genetic mutation, genetic counselors are a great resource for that. And a lot of times just finding, just searching on the web, like who could be, under your insurance, just ask your primary care provider for a referral or even otherwise. But MedStar does have genetic counseling service and they see any patients with cancer or family history, absolutely.
What is the process for getting genetic counseling? What's involved?
Yeah, so it's these days, most of these consults, I think, have gone virtual. So it's very convenient for patients. Once you get to an appointment with a genetic counselor, they sit down with you, they talk about your family history, they do a detailed, what we call family tree or family pedigree. And then there are criteria and assessment to see if you qualify for genetic testing. We have risk prediction models. We have other criteria that will qualify you for a particular genetic testing. And then there are different panel, as we call it. We could be like one gene tested to hundreds of genes can be tested. And that process is then explained at that time what is best for the patient. So if the patient qualifies, it's usually a blood test or a saliva test that can be done. A lot of times these are very convenient. The approach we use blood test a lot of time because we also get additional genomic assessment on that. There are other, the thing with blood tests, you have to come to the hospital to get the blood draw. but there are also facilities where someone can come to your home to get the blood draw. The other option is saliva test. So these are the two options usually patients will get tested. We get the results back in a few weeks. We call the patient, we sit down with the patient and talk about the risk, like if they have a gene mutation. So usually a clinic visit followed by a blood draw or a saliva testing.
Okay. What types of genetic syndromes put me at higher risk for colorectal cancer?
Yeah, there are multiple common to uncommon to rare conditions in the world of GI cancer or colorectal cancer. I mentioned Lynch syndrome because I think everyone should know about Lynch syndrome. Why everyone should know that? Because it's 1 in 300 person. That's a very, very common, it makes it a very common prevalent condition. If you do the math in DC Metro, there are 10,000 people living with Lynch syndrome and we have no idea where they are. We're not seeing 10,000 patients in our clinic. So that's the number, just population based, and finding these patients is really a priority. So there are risk prediction models, there are family history criteria, but they're not perfect. And that's why if you have a sense of like, if you have family history of early onset cancer or colon cancer, multiple cancer, think about it. But Lynch is one thing I would suggest everyone understands what it is. And if you have any concern, to look into that. But there are also rare conditions. Some of the conditions we diagnose on colonoscopy. We see a patient with hundreds of polyps, well, that could be genetic. Lynch is not like that. You may not have any polyp on exam. You may have 5 polyps on exam. So it's tricky. So there are conditions which produces polyps to like hundreds of polyps or no polyps. And there are other rare conditions where you have other organ cancer, and those are much more rare and may not be seen on a daily basis. But Lynch is something I'm saying this many times because I feel like everyone should hear about it.
Yeah, that's very important. What are the next steps if the genetic testing comes back with gene mutations?
Absolutely. And that's the time to sit down with a genetic counselor or the genetic expert and go over what does it mean. So a gene mutation, if we do most of the time, now we do multi-gene panel testing that is not looking just for the Lynch syndrome gene, which are like 5 genes, but we're looking at various other genes that increases your risk of other solid organ cancers. So it can have breast cancer genes or uterine cancer genes and many other cancer genes. And when it comes back, if it's positive, or you have that gene alteration, we go over what does it mean. So what organs does it affect? And how do we implement a screening plan for that? Most of them, we have a screening tool. Sometimes we don't have a perfect tool, but we can still provide some guidance and then keep an eye on that because things will change. Genetics world has changed tremendously. Like how we used to test 10 years ago, 15 years ago has completely changed. So same with the recommendations has changed and will keep changing. So as we get to know more, we can put in more surveillance. But at this point, when we test for them, we can more or less put in a screening and earlier surveillance for the patients, and then also test family members, because that's where the key is. Unaffected people who are not having a disease right now, cancer right now, and prevent that in future. Not only colon, but other cancer that can be affected by the gene alteration.
I think you just answered my next question. If you have a family history of colorectal cancer or GI cancer or any cancer, it's important to think about genetics.
Absolutely. If you have anyone with colorectal cancer, if you have anyone with any cancer less than age 50, think about it could be genetics. It may not be genetics, but think about it and talk to your doctor. You don't have to have colon cancer in your family to carry a condition that increases your risk of colorectal cancer. Because most people who carry may not even develop cancer, but many people will. So you have to just be aware and discuss this with your, and also history of polyps in family, just like Dr. Sloane mentioned. So those are the things to think of. There are other conditions like inflammatory bowel disease and things like that, that you have to be aware of and talk to a family member. But yes, family history of colon cancer, any GI cancer, highly relevant.
Right. If I'm at risk, high risk for colorectal cancer, what should I do next?
So I think the first thing that many of us struggle with, many patients struggle with, is understanding, are they at high risk? So, having an honest dialogue with your family for those who are able is really invaluable. And again, that's not just mom and dad, it's your siblings, it's your children, who may have conditions that you're unaware of. So having that dialogue, and as Dr. Kanth mentioned, from there, talking to your primary care provider about being referred for the appropriate screening. High risk individuals who are at high risk for colorectal cancer should undergo colonoscopy-based screening. The stool-based options are not going to be appropriate for them. But as Dr. Kanth kind of alluded to, colonoscopy may not be the only screening that's needed. A person may need upper endoscopy in the case of Lynch syndrome. They may need urine testing annually. So it's important to have that second conversation with your primary care so that he or she can direct you towards the appropriate screening. And then again, always consider genetic counseling if you think that you're at high risk.
Great. Thank you, Dr. Sloane. If you're just now joining us, thank you for tuning in. Today, we're joined by 5 specialists from MedStar Georgetown Cancer Institute, Dr. Dana Sloane, Dr. Priyanka Kanth, Dr. Reetu Mukherji, Dr. Brian Bello, and Dr. Luther Ampey discussing colorectal cancer. Again, March is Colorectal Cancer Awareness Month, a month dedicated to increasing awareness of this prevalent disease. Colorectal cancer is impacting an increasing number of Americans, so it's important to understand the risk factors. So let's go into treatment. What are the stages of colorectal cancer?
So once you've been diagnosed with colorectal cancer, usually by way of endoscopy and a biopsy, the next step is to understand what the stage is, because stage really impacts our goals of treatment and what the potential treatments are for our patients. So we stage colorectal cancers using a few metrics. One is how deep through the wall did the colon cancer grow. The other is whether it has traveled to nearby lymph nodes. And the third is whether it has traveled to farther away organs or metastasized. So our colon, if you think about it like a pipe, usually cancers start on the innermost layer of the colon and grow out. And stage 1 disease is when tumor has grown in the colon wall, but it hasn't really grown beyond the muscle layer, and it has not metastasized or traveled to any nearby lymph nodes. This is our earliest stage of colorectal cancer. Stage 2 is if the tumor has grown a little bit deeper through the wall of the colon beyond the muscle layer, but has not yet traveled to the nearby lymph nodes or farther away. Stage 3 disease is disease that has traveled, grown into the nearby lymph nodes, but not yet farther. And stage 4 disease is when tumor has traveled and landed in other organs or lymph nodes farther away, or what we more often refer to as metastasized stage 4 disease.
Okay. How do you treat early stage colon cancer?
So after a CAT scan is done, this is usually done after the diagnosis is made with a colonoscopy. We hope that the CT scan doesn't show any evidence of disease elsewhere, like metastatic disease, as she just mentioned, either in the liver or the lungs. Usually the next step is we go to surgery. We mentioned using the analogy of the bowel is like one long pipe. The rationale of surgery is to remove that pipe with the tumor and the surrounding fatty tissue and putting that pipe back together. So that's usually what we do next. And after about 1 week or so, we have the final pathology that tells us what stage it is, stage 1, 2, or 3.
Okay, thank you. When is chemotherapy needed for colon cancer?
So chemotherapy is indicated in certain stages of early stage colorectal cancer, and the goals of chemotherapy, especially after a surgery, are to try to improve the odds of cure by really attacking micrometastatic or microscopic levels of small amount of cancer that we may just not see yet or that were left behind after surgery. For stage 1 colon cancer, the earliest stage, surgery cures the vast majority of patients, and there's not really a survival benefit of giving chemotherapy in this setting. Stage 2 disease is a little more complicated. The data we have in this setting, there are some studies that have shown that there's not really much of a survival benefit, whereas others have shown maybe a 3 to 5% minimal survival benefit. And when we think about these therapies, certainly it's usually on the scale of 3 to 6 months of chemotherapy with pills or through the IV. These have side effects such as neuropathy, issues with the nerve, GI toxicity, also effect on the blood count. So they're certainly not without any toxicity. And so for stage 2 disease, it's often a discussion with the patient about the potential benefits of chemotherapy weighed against some of the side effects from the treatment. And often we also risk stratify stage 2 patients further based on some clinical and pathologic findings to see whether they may benefit more from chemotherapy than not. Stage 3 colorectal cancer, where the cancer has become a little more advanced and traveled to the nearby lymph nodes. If we talk big picture average numbers, we think surgery may cure around 50% of these patients. But we've seen with the addition of 3 to 6 months of chemotherapy after surgery, we may improve these odds to around 70-75%. Based on these benefits, we do offer, our standard of care today is to offer adjuvant or post-surgical chemotherapy to patients with stage 3 colorectal cancer. And this is often in the form of 2 chemotherapies, 5-fluorouracil oxaliplatin or capecitabine and oxaliplatin given over the course of 3 to 6 months.
Thank you. How do you treat early stage rectal cancer versus locally advanced rectal cancer?
Okay, great question. So earlier I talked about colon cancer. We talked earlier about as well as the difference between colon and rectal cancer. Rectal cancer is a cancer that's closer to the anus, usually about 15 to 20 centimeters from the anus. It's usually a bit trickier in terms of diagnosis and treatment. So we're going to talk about rectal cancer for a bit here. So one key difference is we added an additional diagnostic step. Dr. Mukherji mentioned stage 1, 2, or 3. We can get an MRI or a special ultrasound to find out what stage it is, or our best guess of what stage it is before we initiate any therapy. So it's usually in the form of an MRI. We can find out if a rectal cancer is stage 1, 2, or 3. If it's stage 1, depending on what kind of stage 1, if it's stage 1 where it's very small, a very small tumor, sometimes we can still go in transanally through the anus and remove it with small incisions. Sometimes if it's a larger stage 1, we are doing surgery, like I mentioned before, removing part of the rectum and trying to put things back together. Many times we see patients what we call locally advanced rectal cancer, which is stage 2 or 3. And it's a very different pathway. And I know Dr. Ampey will be speaking soon about it, but that pathway for stage 2 or stage 3 rectal cancer is a long treatment. It's usually chemotherapy and radiation first for 6 weeks, and then chemotherapy for 3 to 6 months. And then we look again with a colonoscopy, CAT scan, and MRI to see if the tumor has responded. The hope is that the tumor has shrunk to make surgery more successful. And sometimes, and especially in these days with better treatments, we can see sometimes the tumor is gone completely, which is a great scenario for the patient.
Are there minimally invasive surgical options for colorectal cancer?
Yes, for both colon and rectal cancer, we usually try to do small incision surgery. That's called laparoscopic or robotic surgery, where we can use instruments that are very small, about 1 centimeter in diameter, usually spaced out through the abdomen, and then maybe one longer incision to extract the tumor with the colon.
Are there side effects from surgical treatment?
Yes. We always think about this as short-term versus long-term. The short-term risks of surgery, just like with any surgery, include bleeding and infection. The long-term risks, sometimes it's when we think of the bowel as our GI tract and especially the colon absorbing water. When we remove part of the colon or rectum, sometimes our stools are a little bit runnier than before surgery. Some of those risks are mitigated by small incision surgery, as we talked about. So usually if we do small incision surgery, people get out of the hospital faster, they have less pain, they can go back to their normal activities much faster. But we balance all those risks of surgery with the benefit of surgery. Many times these surgeries are curative, so we balance that against the risks of surgery.
Wow. Are there clinical trial? Nope, I skipped ahead. Sorry. What is the upfront role of chemotherapy and radiation therapy for rectal cancer?
I'll go ahead and start with that, Dr. Mukherji. Dr. Bello alluded to patients who have more locally advanced disease requiring a little bit more preparation before they can go to surgery. So it's reasonably straightforward when a patient has disease isolated to the rectum, meaning it has not penetrated through the wall, nor has it gone to the lymph nodes. Dr. Bello or a colleague can go right in and take that out. When the tumor becomes a little bit more involved, meaning it's lower down toward the anus, It might have some ability to go to the lymph nodes that we see from MRI or other studies, or the tumor has gone through the wall. We like to give preoperative therapy, we call it, either with chemotherapy alone first, chemotherapy radiation, and sometimes we'll combine the two. So oftentimes what you'll see us do, and we have several patients on treatment currently, where we're doing chemotherapy with radiation to the pelvis, including the rectum, including the lymph nodes, which are areas where tumor can spread, in order to downsize those tumors to make them more amenable for surgery, number one. And by doing that, it helps us reduce the risk of local regional recurrence. In patients who have tumors that are lower down in the rectum toward the anus, doing chemotherapy and radiation, and sometimes even followed by chemotherapy, we call that total neoadjuvant treatment, we can actually downsize the tumors to make sure that we can preserve the anus so that patients will not have a permanent colostomy. The other reason to do that too is that by doing upfront treatment, we can actually get patients through treatment a little easier. They tend to tolerate it better. And we also have an opportunity up front to address micrometastatic disease, something that Dr. Mukherji addressed a little bit earlier in terms of metastasis. So upfront treatment is very helpful as disease gets more advanced. And we know that there's a risk for greater local regional relapse and also for distant recurrence.
Thank you. Are there side effects from treatment?
There definitely are. But the good thing I'll say is that we can manage most of those very, very nicely. So I'll start with radiation. When we treat with radiation, radiation is a localized treatment, much like surgery is. So with the techniques that we have nowadays, and we have very advanced techniques, we can actually shape the radiation, avoid structures like the bladder, the small intestine, so that we can actually mitigate diarrhea and enteritis, which is inflammation of the bowel. Therefore, when patients get treatment, they can actually get through it fairly well with having some change in their bowel habits, but for the most part, nothing extreme. When we couple that with chemotherapy, certainly there's a little bit more of an additive side effect profile, and Dr. Mukherji touched on some of those things before. They can be a little bit more diarrhea, patients have a little bit more fatigue. There might be some what we call hand-foot syndrome, where the skin gets affected on the hands and the feet, but for the most part, that's actually well tolerated as well. And certainly when we do systemic therapy, which chemotherapy is one of those, we have to keep track of the blood counts as well. So all of those things being said, we can manage those side effects very nicely to get patients through treatment. And with the techniques that we have, certainly with radiation, those things are really modulated quite nicely.
Okay, good to know. Are there clinical trials available for colorectal cancer?
There are certainly clinical trials available for colorectal cancer. And before I kind of go into that, I think, as we've talked, colon cancer is managed a little bit differently than rectal cancer. And if we focus now on the rectal cancer, it really is complicated to approach these patients today, but in a good way, because we have a few different approaches we can take. And often we're balancing the toxicities from some of these treatments like surgery, radiation, which may render patients, and chemotherapy, which may render patients having some long-term issues with bladder, bowel throughout life. And what we're also noticing is younger and younger people, unfortunately, are being diagnosed with these cancers. So some people who undergo treatment may live with some of these side effects for many years of their life. So we're balancing some of these toxicities and whether they end up with an ostomy with survival benefits. So kind of a paradigm we've seen is we try sometimes to be a little more aggressive with chemotherapy and radiation and see if we can shrink tumor down more, even to the point where in some patients, we may be able to spare them surgeries in a very select few cases with close surveillance. And so a lot of our trials today are kind of looking to see what are the best combinations of chemotherapy and radiation to be able to shrink things down, maybe spare some patients surgery. What sequence do we do it? Radiation first, chemotherapy first, which chemotherapy, 2 drugs or 3 drugs? So we even have trials at Georgetown that are looking to answer some of these questions. The other thing is when we talk about rectal cancer or even colorectal colon cancer, I mentioned in the adjuvant setting, post-surgical setting, there's controversy over which patients may really be benefiting from that additive chemotherapy versus some people are just cured with surgery alone. And wouldn't it be nice if we had a tool that could help us risk stratify and say, you are cured, you do not need 3 to 6 months of chemotherapy that's going to leave you with neuropathy, or no, you still have some microscopic disease, you may benefit from chemo. And until recently we really haven't had a tool to help us guide us in that way. But in the past few decades, we've seen an enormous amount of research into a blood-based tool called circulating tumor DNA. And there are many different assays out there, different forms of this test, but in essence, it's a blood-based test that we think can help us identify potentially the earliest sign of cancer recurrence or microscopic levels of cancer. What we know today through many observational studies is this test is highly prognostic. It can give us information about who is high risk for still having cancer out there, even if we can't see it on a scan. But what we don't know and what we're trying to learn is how to use this test to make decisions for patients after surgery, especially in the adjuvant setting. And there are clinical trials that are looking at using this test to stratify patients and augmenting or increasing the adjuvant chemotherapy regimen, or potentially even sparing some patients chemotherapy. So certainly many trials in the early disease space. And another thing I'll quickly mention is that kind of alluding to what Dr. Kanth had mentioned before, molecular testing, identifying patients with Lynch syndrome or other molecular markers that mimic Lynch syndrome is important, because we think immunotherapy actually may work better in some patients with Lynch syndrome rather than chemo. And some trials have also been looking at using immunotherapy added to chemotherapy rather than chemotherapy alone in the adjuvant setting. And we're waiting for some of that data to come out, which we're hoping to come actually maybe later this year.
That's great. If I've been diagnosed with colorectal cancer, should I get a second opinion?
I think it's always a good idea to get a second opinion. I encourage a lot of my patients to get second opinions. In colon cancer, it may be a little bit more straightforward, upfront, if a patient potentially can go for surgery or not, and, you have a discussion about adjuvant. Second opinions may help patients identify if there's a clinical trial that's applicable for them that may not be there at their primary institution. I think, and maybe Dr. Ampey and Dr. Bello can comment on this too, but in rectal cancer, I think if, there may be differences of opinion in approaching certain cases if you go to different institutions based on the comfort of performing certain operations and radiation. So I think especially with locally advanced rectal cancer, it doesn't hurt to get a second opinion. And I encourage many of my patients to do so, since sometimes the answer is not so straightforward and there may be a few different potential approaches.
Yeah, that makes sense.
I would certainly agree with that. And the other thing I would throw in, though, is that even if one were to go to one institution, and so in the MedStar Georgetown Cancer Institute, we actually have very collaborative multidisciplinary discussions. Mm-hmm. So all of the people that you see on the panel here interact quite frequently and discuss cases. So if you go to see a physician, you're not necessarily seeing one physician, you're seeing a group of physicians. And so there is sort of an internal second, third consultation that you're getting all the time. If you go to other institutions, as Dr. Mukherji said, you're likely to get difference of opinions, but certainly you're probably going to get a recommendation that's going to be very similar to what you might get at our institution. But for the most part, we work in a very collaborative fashion. And so there are lots of discussions that go on and lots of different angles of approach that we take.
Yeah, I agree. I think all the hospitals here have a weekly tumor board where we present every new case, every new colon cancer case, every new rectal cancer case, and make sure that all radiation oncologists, medical oncologists, surgeons all have a good consensus plan for the patient. And we always ask if this patient's suitable for a clinical trial. So I agree.
That's amazing. How do you manage, and I think we've touched on this a little bit, but how do you manage stage 4 colorectal cancers?
So stage 4 colorectal cancer, often we have to take a somewhat personalized approach to different cases, because it depends on what degree of metastases a patient has. There are some patients who have colorectal cancer that have metastasized or spread just to the liver. And in select cases, if we think that a surgery to the primary lesion and the cancer in the liver can render a patient disease-free, in some cases, we may be able to cure some patients with stage 4 colorectal cancer. Now, that certainly does not apply to all cases, but in select cases. So similar to what Dr. Ampey and Dr. Bello was saying, we often even present some of our stage 4 colorectal cancer patients in a tumor board to kind of get an understanding up front. Is this patient someone who is a candidate for surgery? And if they are, the discussion is whether they go for surgery up front, followed by chemotherapy, or some chemotherapy before surgery. Now, in some cases, there might be too much disease, or it's not technically feasible to do a surgery, or there are multiple sites of disease, of organs that are affected, where surgery may not ever be an option. But in our standard of care in those cases is really systemic therapy, or drugs given through the IV, sometimes pills, to kind of treat the yard, if you will. And these therapies can be in the form of chemotherapy, drugs that affect DNA and cause DNA damage that cause cells to die. It can be in the form of targeted therapies. And in a few cases, the minority of patients, around 5% or so, immunotherapy, such as those patients with Lynch syndrome. So one thing that is very important and critical to do in patients with stage 4 disease today is to do molecular testing on the tumor. This is a little bit different than what Dr. Kanth was referring to about looking for hereditary mutations, but rather testing the tumor specifically, because we use this data now to guide the best frontline or upfront treatment regimen for patients by adding targeted therapies or identifying therapies that they may not benefit from. And some of these markers that we look for are microsatellite status, RAS mutation status, BRAF mutation status, HER2, among others. And as always, looking for clinical trials in any line of disease treatment is important too.
Thank you. And a question for everyone. What are you most excited about in the future of treatment?
So I'm not sure what order we're going in here, but I would say as I guess a diagnostician, I'm excited about two things. Number one, the future of screening. I believe that Dr. Mukherji mentioned serum biomarkers. There may be value in those blood-based tests, not only for prognosis testing, in other words, how can I manage this patient who already has a cancer diagnosis, but also the potential for using this as a screening modality in the future. They are, I would say, not quite ready for prime time for the broad majority of the population, but it would be great, right, to have an option where a patient can get a blood test to understand, what their risk is for a colorectal cancer or an advanced polyp. There's also artificial intelligence, so the AI-guided colonoscopy is becoming a thing. So there are, I think, going to be applications for AI in the future that will enable us to screen patients in a more effective and a more efficient way. But I'm also optimistic about the future of awareness. As heartbreaking as it was when Chadwick Boseman passed away in 2020, I will say that really opened the floodgates for questions to be asked by my younger patients to say, well, hey, am I at risk? Should I be screened? I would say particularly, for my, young African-American male population, there was a heightened awareness that came with losing somebody so young who appeared so vigorous and so healthy. So I think that the deeper the awareness of colorectal cancer as an entity, and also with regard to screening options, and the broader that's understood, the more patients we're going to be able to meaningfully screen and also hopefully prevent colon cancer from ever developing.
I can follow up on that. I completely agree with Dr. Sloane's all the comments and also the awareness part. I feel like the world of genetics has changed so much, and this will evolve even more, just like Dr. Mukherji mentioned, immunotherapy based on molecular markers. And we are hoping that this field will explore more options. How do we treat early, or how do we even detect these patients early? So that would be an exciting, again, non-invasive markers would be great to find, or better ways to find these patients who we don't know where they are at this point, and not all of them fit into these criteria. So finding better ways to identify high-risk patients would be next step in preventing colon cancer. Awareness, I totally agree with that. This is my biggest message as well, that talk to your family members, find out what you have in family that you were not aware of, and that could put you at increased risk. So absolutely discuss with your family members. And whenever I see an article in Post or somewhere that early onset colon cancer is rising, it's actually a good thing that people are talking about it. So absolutely.
That's great.
From a surgical standpoint, I'm always excited about improvements in surgical technique, how to do surgery less invasively through small incisions, more efficiently, getting people through the surgery safely with less complications, less hospital stay, without a big impact on their quality of life. Definitely excited about new screening. I'm definitely excited about the subset of patients for rectal cancer that we can give all this upfront therapy to, and the tumor shrinks in a way that we can just observe those patients and they don't need a surgery. So.
And is there one message that you would want our viewers to take away from today's broadcast?
I can start with that. I think to kind of echo what many others have said, you know, screening is very important. Also understanding that there's this trend that we're trying to understand better about why younger and younger people are being diagnosed, just being aware of that. So, you know, if you or family members have symptoms that are concerning, talk to your primary care doctor, talk to a gastroenterologist. I think the other message is that, you know, if you have a diagnosis of colorectal cancer, you ask your doctor about the molecular testing, about whether there's a clinical trial applicable. Clinical trials are the way we move the benchmarks forward. And so it's, you know, if you can find a study that's applicable to you, talk about whether this is a good fit for you. And just understanding that for many of these diagnoses, like Dr. Ampey and Dr. Bello had mentioned before, it is a multidisciplinary approach. It is not just one member of your team. It's your oncologist, your gastroenterologist, your radiation oncologist, your surgeon, nutritionist, social workers. And so it's important to have a strong multidisciplinary approach to your cancer if diagnosed.
That's great. That must be very comforting for our patients to know that there's such a great team behind them. Anyone else?
I would say I usually give all my patients kind of a three-pronged message. One is to, you know, modify the risk factors that are under your control. So if you love fried foods, love them a little bit less. You know, try to get a diet that's richer in fiber. Be physically active, even if only for 15 minutes a day, a few times a week. Number two, have those conversations. You know, talk to your family if you're able. And then once you do that, talk to your primary care. I think there's a certain fearfulness for some patients around the notion of screening. But, you know, again, your PCP can have a dialogue with you and get you to see a gastroenterologist, you know, and talk about what your options are. And then number three, you know, just get screened. I think that, you know, there's so much conversation about what's the better test. The best test is the one that you're willing to have, whether it's a stool-based option, whether it's a colon visualization option. Take your pick, but get screened, because I think Dr. Kanth mentioned earlier, you know, colorectal cancer is a preventable illness for so many patients if they get appropriately screened.
That's great advice. All right. I think that's all we have time for today. Thank you to our viewers for tuning in and to our experts for answering all of our questions. For more information or to schedule an appointment, visit medstarhealth.org/cancer, and we'll have that in the comments. We'll see you next time. Thank you so much.
Thanks a lot.
Thank you.
Thank you.